We now move on to the plenary one of this conference. It's titled as Thoracic Trauma, Pearls and Clamshells. The session will be chaired by Dr. Sumana Handagala, who is a consultant thoracic surgeon at National Hospital for Respiratory Diseases, Valisara. Our speaker is Professor Mark Fitzgerald from Australia, who is a well-known figure for us for the last couple of years in our National Trauma Conference. And I now invite Dr. Handagala to take chair and introduce the speaker.
Good morning to everybody. Okay, without wasting time, good morning to everybody. It's my pleasure to introduce Professor Fitzgerald, who is from Australia, and I will just limit his credentials to MBBS, MD research, graduate diploma in internet communications, then fellow of Australian College of Emergency Medicine, then he's an associate fellow of the Royal Australian College of Medical Administration, and he's presently the director of National Trauma Research Institute, and he's also the director of Trauma Services, Alfred Health, Melbourne, and he's an adjunct professor, Department of Surgery, Monash University, Australia, and he's also adjunct professor to Deakin University. So it's my pleasure to introduce Professor Fitzgerald, who has been instrumental in introducing a lot of trauma systems and help to regional centers to speak on thoracic trauma, pearls and clamshells. Over to you, sir.
Well, thanks very much, Dr. Handagala, for the introduction, and thanks for Dr. Jagoda and Dr. Mealaratnayake, who can't be here today, but thanks for the invitation. Also, thank you to the organising committee. It's actually a great conference, a lot of people from diverse backgrounds with shared interests, and the morning's been a great session, so thanks very much. Some of the comments I want to talk about will link to Dr. Disanaike's presentations. This is the Alfred Hospital in Melbourne that was named after Prince Alfred, who was Queen Victoria's son, who was visiting Australia and got shot while visiting Sydney but recovered. And so there was an Alfred Hospital in Melbourne and a Royal Prince Alfred Hospital in Sydney set up immediately after that. And it was basically a surgical hospital because it was introduced, one, after a big population increase into Melbourne, and secondly, because anaesthesia had been invented. And there were two surgeons in Melbourne who couldn't get their patients into the only hospital at the time, the Melbourne, which is the Royal Melbourne Hospital now. So they built a surgical hospital south of the city to basically deal with surgical problems. And it's got a long history of surgical innovations. And from that beginning, we've got this large trauma centre as one of our activities. The key feature is a helipad immediately above it. There's 5 open-ended receiving bays with laminar flow and inbuilt imaging and such like. And there's a whole collaborative effort for people receiving, resuscitating, treating and then rehabilitating these patients. And so that's myself and the registrar. At the patient, there's emergency doctors and nurses supervising the resuscitation and the blood transfusions. There's anaesthesiology people involved. They all come down because of the paging system we have. The operating room are directly above the trauma centre, and obviously the surgical people attend as well. So everyone's integral into this team event. The hospital's a strange hospital because most of its activities are what we call quaternary. So there's not a large local population. Half of our patients come from more than 40 kilometres away. And it's a large education centre, a large research centre. It costs a lot of money to run. There's 10,500 staff at the hospital, and the university has a campus on the hospital. It's a large research centre. And it really is the international leader in trauma, critical care, heart and lung transplant, and as the previous speaker was referring to, ECMO. At one time during the COVID pandemic, they had 36 patients on ECMO in the ICU with a survival rate of better than 85%. One of those patients was on ECMO for 6 months. So it attracts people who are interested in this sort of work. And this is a sort of map or overhead picture of the hospital, and you can see the universities either side of the hospital embedded in the facility, in the hospital in the middle. You can see the helipad on the right, and these are the clinical trials that were being conducted a week and a half before I came to the conference. So there's over 500 clinical trials. It's a large research centre. In fact, there was a recent study, a CSL TAP study, that recruited 126 trauma centres in the United States, the UK and Australia. And the Alfred rated number 3rd in the volume, and we don't have much in the way of penetrating trauma, unlike the 2 US centres. So we rate number 1 in blunt trauma injury. And if someone comes in with a gunshot wound, and I'm sure Scott has the same experience in Liverpool, everyone comes down to have a look at it because it's not a common event. And we admit 10,000 patients, trauma patients per year, and 1,700 of those are major trauma patients, so they're either admitted to intensive care, have immediate life-saving surgery, and some of them die. This is the history of the trauma service. It's basically a surgical history. There's a lot of involvement in various world conflicts. The Royal Australasian College of Surgeons was set up in Melbourne, partly because of the surgical interest, but also partly because it was a southern city and pretty immune from any impending wars or conflicts. The first bypass surgery at the Alfred was performed in 1955, 70 years ago. And then more recently we've moved into a multidisciplinary service with 7-day-a-week allied health, including physiotherapy, OT, speech therapists and such like, and nurse practitioners. The interesting thing about the Alfred is it was basically founded by nurses. The original director of nursing was a student of Florence Nightingale, and she was the first matron and set up the first nursing school in Australia in 1880. And all of our programs involve nurses and doctors. So the doctors breeze in and out while the nurses are with the patients 24 hours a day, and so we need both groups heavily involved. And in the latter part of the last century, we calculated that about 30% of our people were dying unnecessarily from major injury. And so both sides of politics had a review and decided that rather than, there's 136 hospitals in the state, and they decided that all the major trauma would be treated at one of 3 hospitals. There's the Royal Children's Hospital that sees children 15 and under and about 100 major trauma patients per year. The Royal Melbourne, which is with Melbourne University across the river, and then the Alfred, which is with Monash University south of the river. And the government thought it was good to have the institutions competing against each other so that one would always try and be better than the other. It's like cricket and football. You always get the best performances if people are competitive. And this is our standard multi-system polytrauma. They have head injuries, thoracic trauma, abdominal trauma, and obviously orthopedic injury. And so our concentration really is on the polytrauma that Professor Zolt-Balog's described and now can be sort of quantified. And I'll touch on that briefly, but very few patients have isolated or single system injuries. And since we introduced this trauma system, which I know Sri Lanka's in the process of doing, our mortality from serious injury dropped by 50% in the first 5 years. And we've been able to sustain that with a gradual reduction. But just the introduction of the system itself was probably the biggest reason why there was a drop in mortality. That people knew how to transfer patients or get patients to the right people in the right amount of time. And that rapid transfer, because it's pretty easy to identify a multi-system trauma, it's pretty obvious, easy to triage, that accounted for a large drop in mortality. But if any of you have got gardens, you'll realise that it's easy to plant things, but it takes a lot of work to sustain them. And it's the same with any human system. They're set up with enthusiasm and goodwill, but then other generations of people come in on top of it, and you have to set up something that's going to be able to be maintained and continually improved. I'm not too sure whether you can see that down the back, but these are the trauma centres in Australia and New Zealand. We have a sort of binational collaboration. In fact, the trauma registry includes both Australia and New Zealand, and the Alfred Hospital is up the top there. And then the Royal Melbourne's actually below it, because there's only true trauma centres for approximately just over 7 million people, adult trauma centres. While other cities like Sydney's got a more distributed trauma centre. There's, I think, 6 trauma centres in and around Sydney, and each of those models have got pros and cons. So if there's a mass casualty, you want to be in Sydney, because you haven't got all of your eggs in one basket. Whilst during the Black Saturday bushfires in Victoria, there were really only 2 receiving hospitals, and you can quickly get swamped, particularly if there's conflict. You're more vulnerable, but on the other hand, you get to see a greater load of trauma, and it's a greater place, I think, for training. And if you look at our urgent surgeries for all trauma missions, I'm slowly working towards thoracic trauma. So for the people who are really interested, you'll just have to be patient. But this is the introduction to it. You can see that the red represent hemorrhage control surgeries, and the blue represent neural salvage. So either primary craniotomy or surgical decompression. There's a lot of spinal injuries that come through the hospital. And then obviously some people have both of these things, but the neural injury and the hypoperfusion associated with shock are intimately related. And I'll demonstrate shortly that if you can look after people with neurotrauma who've got polytrauma to reduce those secondary impacts from shock and hypoperfusion, you'll actually reduce the mortality and improve the outcome from head injury. We've known this for a long time, but it's been difficult to statistically prove. And so what we looked at is the first 20 years of major brain injury data coming through the Alfred Hospital. And we have a pretty good scope. It's a lot smaller state than most other states in Australia, and we've got 5 helicopters that cover the majority of the state, and then several fixed-wing aircraft, so people can get to us a lot faster than, for instance, Western Australia or Queensland, which are huge states, and transfer times are quite long. But the average pre-hospital time on the helicopters from accident to arrival is 87 minutes for a state that's approximately 900 by 1,100 kilometres. And you can see the unadjusted and then regressed mortality data from brain injury. that basically the first 20 years, 2 decades, dropped from just over 12% to 4.1%. And the people who benefited the most weren't people with relatively minor head injuries. They were the people with AIS 5 and 4, and particularly the blunt polytrauma patients. So only 20% of the major head injury were isolated head injuries. Most were polytrauma, and with improvements in imaging, particularly spiral CT institution, which is why we've chosen those dates, and a more sort of targeted approach to operative intervention and angio intervention, the resuscitations improved a lot, and because of that, the neural outcomes improved a lot as well. Now, the only rider I should give for this slide is that we didn't include people over the age of 70, because there's a lot of people over the age of 70 with head injuries who have a lot of cofactors and a lot of comorbidities. And as you know, in patients with polytrauma, there's only a handful of factors, 3 that actually really make a difference. The first is their age, the second is their ISS, and the third is whether they have neurotrauma or not. So we excluded that group, but this is relevant data for 16 to 70-year-olds. And we used a not commonly recognised, but an adjunct indicator of how well people were resuscitated, because most people don't want to be resuscitated to be vegetative, and the concern was, well, if you do this, do you have an increased burden on the patient, the family, the community? But you can see as a surrogate marker of discharge to home, we went from, in 2001, 31% of people getting discharged directly to home, to up to 68% now of people with major head injury. And the average length of stay is 7.4 days, and it hasn't changed. So not only do you reduce people's mortality by addressing initial resuscitation, early operative intervention, and adjunctive therapy, but also you increase their likelihood of independence and functional recovery. So I'm just going to digress now to thoracic trauma, and the reason I want to talk about thoracic trauma is because it really is now probably the most commonest life-threatening injury that we deal with, but also the one with the greatest prospects for recovery with early recognition and intervention. I'm just going to briefly talk about the incidence. I'm going to talk about ultrasound and the pros and cons. I want to talk about chest decompression and then just briefly touch on resuscitative thoracotomy. I'll try that again. Sorry? No, there's no video. No. I would never trust videos at presentations. You get a question mark. But as people know, with thoracic trauma, it's currently responsible for up to a quarter of the deaths from trauma, and it contributes to another quarter of deaths for people with orthopedic trauma, truncal trauma, neurotrauma. So it's very important to be able to manage it. And the incidence is actually increasing, at least in Australasia. This is a man who was spearfishing off Port Phillip Heads, and one of his friends was a bit reckless, and he's come into the hospital with this spear that's missed his LV sitting in his chest. And I should announce, this is completely off the script, but my daughter, who's a junior doctor, was walking along the beach in Queensland this morning, and an English tourist had been washed out to sea, and so she's very athletic, so she managed to swim out and rescue him, and he's recovered. He's Welsh, so I asked her, did she have to give him mouth to Welsh resuscitation, and she said it wasn't necessary. So it's the second commonest cause of death from injury. It usually occurs in multiples. I mean, occasionally occurs by itself, particularly with penetrating trauma, but often people with thoracic trauma have got a whole manifest of other injuries you have to deal with and prioritise. And the other thing is that injuries evolve. So when I was little, Ivan Kapichnikov pushed me off the big slide and I broke my arm and I was immediately aware of it. And people think that you become immediately aware of thoracic trauma, but sometimes it takes days, sometimes months, and occasionally years to evolve. And sometimes diagnoses are unreliable on a single examination. So here's a man who's been driving east of Melbourne during a storm, and a tree branch has fallen through the windscreen and struck him in the chest. And you can see that he's got this paradoxical movement of his central chest where he's got a central flail and he's got impaired ventilation. But the important thing, the remarkable thing, if you look at this slide, is he's got betadine all over his chest, and you think, well, what's the betadine there for? And the second thing is, if you look at his neck veins and his peripheral perfusion, you can see that he's got tamponade. And so we have a very rigorous approach to the management of chest injuries to ensure the best outcome. And we understand that people with tamponade at our hospital, when we measure it from the decision to take them to theatre, even though the operating rooms are not very far away, to the time the knife gets to the skin, retrospectively is 42 minutes. So a lot of these people have their life-threatening chest injuries dealt with on arrival downstairs in the trauma centre, which is part of the emergency department. Getting back to how injuries evolve, if you have, this is his RV, you can see a little hole in it post-injury. But you see all of these injuries, tension pneumothorax, massive hemothorax, tamponade, flail, diaphragmatic ruptures, aortic injuries. They may not be apparent on the initial examination. And what's really, I think, revolutionised the management of thoracic trauma, firstly, is them getting to a centre that can deal with it as quickly as possible. Secondly is the recognition that it's a process in evolution. And the third thing is high-definition CT scanning. It's made a huge difference to the way that we manage these patients. So when I was a lot younger doctor, with the pixelation on the old CTs, we really only used it for head CTs. But as the imaging evolved, we've had to change our practice significantly, and it's to the benefit of the patient. But all of our trauma consultants are all expert at image interpretation because it's now just a standard part of the practice. These are the top 10 DRGs, or diagnostic related groups at the Alfred, and you can see that chest trauma is 2 out of the top 4 of these injuries that come in, just to emphasise that you need to be very familiar with them if you're going to look after these patients. And at least half the patients don't really need much done to them. They need support, they need their other injuries treated, they need analgesia, they need physiotherapy. About 40% end up with chest strains, either one or more. 7% need, in our system, and you've got to remember that our system is a selective system, so we're getting the referrals of the sick patients, and so we do get a selection bias towards the right end of the curve. But 7% have an emergency thoracotomy, and this is in a centre which has got a relatively low penetrating trauma rate. And then 1% have a resuscitative thoracotomy on arrival. So even though there's a lot of talk about it, it's a relatively uncommon intervention. But we just see it as a continuum of care, from the elderly person with 3 fractured ribs who seems fine at the moment, but you know will be in trouble in 3 days, to the person who's got cardiac tamponade and has got an evolving hemodynamic compromise. And this basically just re-emphasises that point. So one of the biggest problems in trauma is decision making. You know, the commonest reason an indicated procedure isn't performed is lack of confidence of the operator. I mean, it's indicated, it should be performed, and there's often a lot of hesitation to intervene. And that could be for a whole range of reasons. The resources unavailable, the facility doesn't have the equipment that you need, perhaps inexperience of the operator. There's a whole range of reasons, but the linchpin between all of this is the decision processes. And really one of the great advents of 4G and 5G technology is people can connect with their friends. They can, there was an incident down at Warrnambool, it was in the press, so it's not confidential, of an English track rider, and she was crushed by a horse, and the surgeon, Warrnambool's a little town on the coast, and the surgeon there did a laparotomy, and she'd actually taken off the bottom half of her liver, and that was in her pelvis when he opened. And so he was able, just with Apple iPhones, to get advice over internet on how to control the hemorrhage, pack the liver, and then transfer the patient to the Alfred. And I understand that the same thing's happening in Sri Lanka. You know, the technology's really improved the access to expert care, and it's been a real game changer. In fact, in in southern China, in Guangdong province, what we've done is we've introduced into 200 hospitals there a 5G connectivity with ambulances. So you can actually see inside the back of the ambulance. You get feeds from the vital signs, monitors and stat chemistry and ultrasound. It all goes onto the EMR, and the handover occurs before the patient arrives at the hospital. And since we've introduced that around Huizhou, east of Shenzhen, their mortality's gone from 30% down to about 7%. So technology can really make a big difference, particularly communication and decision support. So everyone knows about damage control resuscitation. And there's some codicils that people need to be aware of. I'm not too sure in your emergency departments where someone comes in with severe trauma and you have they're hypoxic, they're hypotensive, and the trainee emergency doctors want to do an ultrasound of their chest, or a chest x-ray, which may or may not be helpful. But actually when it's been studied, you find that there's a lot of false negative rates with ultrasound. We think it's a waste of time, an ultrasound of a chest. If someone's compromised, you just decompress their chest. And also supine chest x-rays in our institution, when we looked at it, they miss 1/3 of significant hemo and pneumothoraces. So you have to be aware of the limits of technology as well, and not hesitate to intervene if it's indicated. Particularly with, for instance, big hemothorax on the left and you can't see any blood in the pericardium, it may just be that there's a rent in the pericardium and they're decompressing into the left hemothorax. We do use it to demonstrate cardiac activity, and that's our first point of call and filling, and it's particularly useful for that, but as I said, it's got some limitations. There's a couple of things I just want to debunk. Needle thoracostomy, we don't use at all. It's unreliable. The needle can go anywhere. This is an article we published 17 years ago. You can get false positives from subcutaneous emphysema. You can hit particularly the pulmonary trunk or outflow tract if there's tension on the right. And it's a blind procedure. And it's with limited effectiveness. And when the British Thoracic Society looked at this ideal location for chest tube insertion, they found that maybe only half the time would the doctors in the hospital get the location site right. Most tubes went in too low. So we use emergency thoracostomy. We use it on the ambulances. We use it on the helicopter ambulances where it's just digital decompression of the chest. And you can put the chest tube in later if they're sick. If someone comes in with extra jewellery, decompress the chest, put them on the scanner with some colostomy bags over the incision and place the drains later. And we use this mid-arm location using the person's skeletal biometrics. So the person's supine, you go from the acromion to the back of the electron, use a caliper technique with your hands, make a mark on the chest, and as you raise the arm to 90 degrees, when we've studied a whole lot of volunteers of various sizes of morphology, it was the correct place all the time. And then we used the pre-hospital mid-arm position on the helicopters where we looked at this series of digital decompression. There were 3 cases out of 180 where it may have been in the incorrect position. But none of the patients were compromised. Just reminding people, during the pandemic, we switched the lights off and you could see the spray of hemoglobin and virus filtering out, so you do have to be scrubbed. And I just want to finally finish on resuscitative thoracotomy. And the important thing with it is you do it early. So that most of the survivors are people who arrest in front of you. If you've arrested and you're 10 minutes down the track, it's very difficult to get these people back, and it's a selection bias. If you're in hospital and someone comes in with a penetrating or blunt injury with pericardial tamponade, you can almost bet it's going to be a very small injury, which will be easily controlled with digits or balloons. And so I won't go through that, but I'll leave these slides available for people who want it. So just to finish on, we have this combined cardiothoracic and trauma approach to thoracic trauma. We use a crucifix position as people come in. We prep them from above clavicle to the abdomen. The ultrasound's done under the drapes of the pericardium. We do early thoracostomies. We tend to come more anteriorly on the left side so that you can actually feel what the LV is doing, to see what the filling's like. Sometimes you can't get adequate ultrasound views, particularly with big stomachs full of gas. We use right brachiocephalic vein access, and we've studied that in resuscitation. It's much more effective than subclavian. We delay intubation, as Dr. Shamila's pointed out, and then if the person needs a thoracotomy, just extend that thoracostomy excision on the left. And usually the trauma doctors will just control the bleeding digitally, occasionally with Foley catheter, give some adenosine and wait for the cavalry to arrive, which are the cardiothoracic surgeons. And then we run credentialing processes, in a pig lab several times a year, just to make sure everyone's credentialed. So in summary, I've just gone across all of these things. I'm wrapping up a couple of minutes over time. I apologise for that. Had the opportunity to visit Nurse Padma and a team down at Gaul, and I know that Sri Lanka's organising this national coordination. It's a very integrated system. It's accessible. Finance, there's no barrier to it. It's interdisciplinary. And the thing about Sri Lanka is it's very responsive and adaptive. People look at the evidence, respond to it appropriately, and are quick and happy to change the system if it's going to be a benefit to the patients. Thanks very much.
Thank you very much, Professor Fitzgerald, for that excellent lecture on trauma care systems and glimpse of thoracic trauma.